Hey everybody, it's Rob Casquejo back in the Dermcast drop-in studio in Washington, DC. We are about to drop some knowledge on you. We're gonna go over some really cool case studies from one of our members. So I'm gonna welcome Sarah Anderson to the Dermcast drop-in studio. How are you doing, Sarah?
Good. Thank you for having me.
Right, so this is, okay, so first of all, this is very cool because we like to feature our members, dermatology PAs, especially when there's some academia involved. So you published some very cool case studies in the JDPA, in the online JDPA offerings. So we're going to talk about that today. So first of all, why don't you tell us a little bit about yourself so that our viewers can know a little bit about you?
My name is Sarah Anderson. I'm a derm PA located in Roanoke, Virginia. I've been practicing for about 1.5 years. I graduated in December of 2023. Luckily got straight into derm and I love it.
Right. Well, we're happy to have you. And you know, by the way, so 1.5 years into your career, I think this is so cool that you're already publishing some case studies. And I think it's a good example for all of our colleagues that, you know, this is really something, it's not as hard as you think it might be to do. And the SDPA actually has a lot of offerings to help people do those things. So, well, let's get into it. So you published 2 case studies. Let's start with the first. And when I saw the tagline of the case, this was about an unusual presentation of a squamous cell cancer. So I'll let you start telling the story of this case study.
So this was a 22-year-old female patient that came in to me. First time that I'd ever met her, had been previously seen by another provider, diagnosed with kind of like a cyst on the face, given the typical doxycycline with no return follow-up. So she came to me on her own, lesion hasn't healed. I talked her through everything, especially since the doxycycline hadn't touched it. I thought, you know, we need to biopsy it and kind of see what's going on. So biopsied it, it actually came back as a poorly differentiated squamous cell.
Okay. And she was 22 years old?
Yes.
You said? Wow. Okay.
Yeah, sweetest patient ever. But I'm glad we found it.
Yeah. So a couple questions about her presentation. When she was seen in clinic, at least in your clinic, how long has she had the lesion?
A couple weeks. I want to say max about a month.
Okay, so it was a fast-growing lesion. So we know squames can do this. But what's interesting, when they sent it off to pathology, you said it was a poorly differentiated.
Correct.
So that's a little more unusual. When we see squamous cell cancers initially, they tend to be well differentiated, especially if they're very acute, the ones that just sort of spring up overnight. So this implies maybe an aggressive histopathology or aggressive subtype of the squamous cell cancer. So especially in this age, 22 years old. So this is already sounding a little bit, you know, outside the box, a little bit abnormal. So in the course of sort of picking this case apart, was there anything else that you found that might have explained why this? And it sounds like she had no specific risk that was known in her medical history. Was that the case?
Correct. Yeah.
Okay. So very low risk population, and then in a very aggressive tumor. So something seems off there. So what did you find in unraveling this case?
So I did a lot of research because you're exactly right. No risk factors. It's very abnormal. So the big thing is that I researched that there was something about a DNA repair gene that has issues. So the thought is that potentially maybe she did have an acne breakout, something happened, and then as your skin is repairing that, something mutated and then developed into a squame.
So this is actually fits into the tail of even classic squamous cell cancers. I'm sure many of us have had a situation where a patient comes in, they have this big ugly squame on their arm, and they say, I was doing gardening work and I poked myself with a cactus spine. I mean, I hear that in Arizona all the time.
Yeah.
And they always say the same thing. I think there's something stuck in there, and it's just this big squame. So there's some traumatic event that inspires inflammation, and then there's this sort of expression of genetic the inflammation lights the fuse of this genetic expression, and then all of a sudden there's a squame there. So it sounds like it may apply to this situation too. So you research this, you sort of pick out, okay, something might be wrong here, but again, it's still, even when we see that, it's in 65-year-olds that have a ton of sun damage. and that's where you see the squame. So this is still, there's still some things missing here in the case. So anything else that you found out in sort of investigating this?
So I sent him to genetics, especially to see if there was any mutations in genes that could be causing this.
Right.
Ultimately, they came back that not a single gene could be causing this, but we don't have the research data to kind of explain if there's a double mutation. So I think there's definitely more research potential to be kind of went through with here.
Yeah.
But with that aspect that nothing like that.
So did they find that she had any aberrant genes at all?
Nothing.
Nothing at all. Okay, wow, that's interesting. So they made a point to say to you, like, there may be some, coexisting mutations that are not necessarily detectable in terms of disease, but there may be something going on that made her predisposed to it. Wow. So now the interesting thing here is 22 years old, poorly differentiated squame, no specific genetic markers, and it sounds like she has no particular medical history otherwise. So this is as healthy as a person as you can get with a really advanced tumor. So let me go back a little bit in your clinical case in managing this. She obviously got surgerized. Okay, and you did Mohs micrographic surgery, I'd assume. And what about monitoring her at this point? What did you guys decide to do in terms of managing her long-term care and observation?
So at this point, she hadn't even been in for an annual, just initial skin screen. Yeah. So I brought her back in pretty much a week after just to look through the rest of her skin to see if there's any abnormal findings. There weren't. So I kind of talked with her. If anything new popped up, I told her I'd get her into my clinic as soon as possible. But right now we're doing every 6-month skin screens.
Great. Okay. So sounds like what we would do with anybody who was high risk. Yeah. Okay. And out of curiosity, did you do any genetic testing on the tumor? Did you look for any aggressive genetic behavior of the tumor?
I believe my supervising physician, who was the Mohs surgeon who did this, sent it off and it didn't find anything.
Okay, great. So we know that those genetic tests are available for the advanced squamous cell cancer. Castle Biosciences, who's a big supporter of the SDPA, has that test to test the more moderately and higher risk lesions for high risk genetics. And the interesting thing is, if you find them to carry those high risk genes, we're not sure exactly what to do with those yet, but probably at least monitor them much closer. So, but this is a classic scenario where, wow, the history and presentation alone are enough to make you want to monitor this person. Okay. So what's the take home for us as clinicians, like in this unusual case?
The biggest take home is to have a broad differential and stay vigilant for your patients. Make sure they're taken care of.
All right, that's great. So, and just monitoring, I think you can add to this the idea that this is why everybody should get a skin exam, right? You just don't know who the outliers are that might just be outside the box. Okay, that's a great case. So your second case had to do more with an unusual presentation of a dermatosis. So why don't you tell us about that one?
So this was a 70-year-old patient who was in remission from breast cancer, has been there for 4 years. She had pretty regular follow-up with oncology, checking for tumor markers, everything like that. Thus far, everything's been normal. She came to me with kind of diffuse pruritus. I started her on the typical antihistamines, kind of brought her back, but she didn't have a rash at this point. I told her, especially with her history, if she did have a rash, to come back in because I'd want to biopsy it. So the rash presented about a month after that. I brought her back in. I did a punch biopsy. The pathologist actually called me and said, "Hey, I've never seen this type of cells before. It had lymphocytes in the path, and recommended a wedge biopsy."
Okay. So that's the call nobody wants to get. The pathologist saying, "I'm not sure what's going on," but so clearly, immediately, after H&E, something weird's going on. Okay.
Exactly.
Right.
So we did the wedge biopsy, and actually that did come back normal. However, with just her history, I was pretty adamant that I wanted to make sure nothing else was going on before starting on a biologic or anything like that.
So your working diagnosis at that point was?
Eczema versus malignancy.
Okay.
Yeah.
Right. Gotcha.
So
specifically maybe atopic dermatitis.
Correct.
Okay. Gotcha. So you did the wedge biopsy, you got to that point, you wanted to work her up. Okay, so what did that look like when you said, let's make sure nothing else is going on? How did you work it up? What did you find?
So I asked her a bunch of screening questions. She had no B symptoms, nothing to be concerning of a cold malignancy. However, with her history, I asked if we could, number one, get her plugged back in with oncology for closer follow-ups, as well as doing some imaging. So fought with insurance for a little bit, but finally got imaging covered, and she had mets to the spine.
Oh, ouch. Oh no. So this must have been perineoplastic. Is that what you? Okay.
Exactly.
Wow. So how long has she been post care for her surgical and oncology care for her breast cancer?
So she was still seeing oncology every 3 months, but now they're seeing her even sooner than that.
Oh my.
And this is a very interesting case because tumor markers were coming back normal. So.
Oh wow. Gosh, with Mets to the spine even. Oh my gosh. And was it the imaging that confirmed it mainly?
So imaging confirmed it. At the same time, I didn't realize that oncology was also getting an FNA. So IR actually had that back at the same time that I had my imaging.
Yeah.
And that also confirmed the diagnosis.
Okay. Oh wow, that's an unfortunate case. And so obviously she'll need some oncology care. What did you do from a dermatology standpoint at that point?
It is a lot of topicals. It kind of went through the explanation that she can't be on prednisone long term. She can't be on biologics, especially with this new recurrent diagnosis.
Yeah.
Which she understood that. So she's on a pretty strict antihistamine regimen as well as topicals.
Right. Wow. So, and how long ago did you make, was this case, did you make this diagnosis?
Probably a couple months, February of this year, around that time frame.
February, so fairly recent. How's your patient doing?
She's great. She's doing great. She has great follow-up with oncology. Like I said, they put her back on adjuvant therapy and things like that.
That's great to know. So, gosh, there's a lot of lessons here. So what's the take home for us as clinicians here?
Kind of the same concept as last time, have a broad differential. I went to the SDPA conference and I learned a lot from there. And the big thing that I took away from that is just because it itches doesn't mean that it's atopic dermatitis.
Right.
So.
Right. Yeah. So I think you're right. And these types of rashes, when you get these sort of odd presenting rashes and they don't fit neatly into some diagnostic box, that you have to start expanding your differential diagnosis. And I applaud you for pressing the workup. You followed your instinct to say something's just not right. And, you did the workup and of course, then, make the sort of morbid discovery that there's metastatic malignancy here. Wow. That's a great case. Both of those presentations were great cases.
Thank you.
So let me ask you this. We'll close with I'm really impressed with you. A year and a half into this, you see these really complex cases. You really pressed in both situations you described. You sort of pressed the idea that something wasn't quite right, and you made some diagnoses, some discoveries, all for the patient's benefit. So what brought you to medicine? How did you end up becoming a PA?
So I actually have a very interesting background. I was pre-law, business in undergrad, and went into the OR in my last semester before I graduated and fell in love with medicine.
Wow. How did you come about going to an OR as a pre-law student?
So I had an intern with one of the hospitals close by, following around the CEO. And he was like, is there anything you want to do here? And I said, I would love to go into the OR and kind of see different specialties and kind of go from there.
So you were sort of doing some research as a pre-law business angled person. Wow. And then they sucked you right into the OR and you never left.
So truly to learn how to manage a hospital staff, because that was the goal.
Yeah. That makes total sense. Wow. That's a great story. So from there, you were, that was your undergrad. Did you start immediately pursuing it? Were you working? How did that come about?
So I graduated in August of 2016. And then I immediately started, I applied to my community college and started taking my prereqs.
Right.
I was a pharmacy tech for about 2 years, which is super helpful. I did great in pharmacology and that was nice.
My gosh, the worst subject of all, if you ask me. Yeah.
And then from there, I went into one of our big hospital systems close by, and I was a medical scribe, a research assistant. And then I decided, either I get into PA school or I need to have a decent job. So I applied to a ortho device rep company and I got hired for them. So I was actually ortho rep when I got accepted to PA school.
Okay. Wow. So, I mean, your journey it wasn't a straight line. It was kind of like this. But so many PAs have stories like that. And that's very interesting. And here you are, a year and a half in, practicing dermatology, blessed with practicing dermatology alongside our physician colleagues. And publishing case studies.
Yes.
So that's great. It's great for the SCPA. It's great for the JDPA. And you're a great story, inspiring to all of our colleagues and to all the, especially newer PAs that hey man, the world's wide open for you academically. So it's a great story. I applaud you on your accomplishments.
And I will say the SDPA has really helped me a lot throughout this time. I was an emerging derm scholar in November, and then I got the Itch Scholar recipient to go to that conference in Charlotte, and now to present the publication. So you guys have been a big help.
I'm so glad you said that, because the SCPA goes to great measures to offer our newer PAs opportunities to really get involved in medicine, into all the levels and nuances of what you can do. The Emerging Scholars Program, the conferences, and the JDPA, our chief editor, Cynthia, she is so adamant about getting PAs to publish and do research. There are a ton of resources from JDPA to help people get published. So you're a great example of all these things. You're a poster child for, hey, the SCPA works for our PAs. Well, that's a great story. We're very happy to have you, Sarah. Congratulations on your publications. And now the bar's high, so we're looking for more now from you. You got a whole career ahead of you.
Oh yeah.
Leadership, maybe more publications. So we're hoping to see a lot from you. I'm sure we will.
Awesome. Well,
all right, thanks for stopping by. It's Rob Casquejo in the Drop-In Studio for Dermcast in Washington, D.C.